Hi, everyone. My name is Josh Fox-Fuller, and I'm pleased to welcome you to today's No Neuropsychology Didactic Series lecture. So as a reminder, the No Neuropsychology Didactic Series is geared towards early career individuals, and we will be wrapping up next week with our last lecture in our current volume of lectures, but there are many other lectures available online as well. The No Neuropsychology Didactic Initiative was created by early career practitioners, researchers, and trainees to help further neuropsychological access to education in our field. We would like to continue to appreciate our donors for their continued financial support of our didactic series. And before we begin with today's talk, just a couple of disclaimers. So the No Neuropsychology Didactic Series is not intended to replace formal training or education in neuropsychology, and the views of the speakers are entirely of their own. So today, if you have any issues hearing this talk, or if you have any questions, please reach out to us over the chat box. But if you have questions, submit them in the Q&A feature. And at the end of the talk today, we'll do a moderated Q&A session. I also really invite you to welcome or to ask questions at any time in the Q&A box, and we can kind of try to address them throughout the talk as well. So without further ado, it's my pleasure to welcome Dr. Robin Howarth today to give their talk about pharmacological treatment and early rehabilitation outcomes in pediatric patients with anti-NMDA receptor encephalitis. Dr. Howarth is a board-certified pediatric neuropsychologist at Children's Healthcare of Atlanta and an adjunct assistant professor in the Department of Rehabilitation Medicine at Emory University School of Medicine. She is also the practice director for the Department of Neuropsychology. Dr. Howarth received her bachelor's degree from Indiana University, as well as master's degrees in education and psychology from the University of Denver and Columbia University, respectively. After working as an elementary school teacher in the public schools for several years, she then went on to earn her doctorate from the University of Iowa in 2010. And then she completed her internship at the Children's Hospital of Michigan and Wayne State School of Medicine, followed by her 2-year postdoctoral fellowship in pediatric neuropsychology at St. Jude Children's Research Hospital. In her current position, Dr. Howarth primarily works with patients and families on the comprehensive inpatient rehabilitation unit. Her clinical interests include acquired brain injury in pediatric populations, including individuals with anti-NMDA receptor encephalitis, moderate to severe TBI, and pediatric brain tumors. Her research interests include examining the neurocognitive outcomes and trajectory of recovery following acquired brain injury over time, as well as examining the utility of assessment measures to serially track cognitive recovery during inpatient rehabilitation. She's also interested in functional outcomes in children and adolescents with various acquired brain injuries, including NMDA receptor encephalitis and disorders of consciousness. So without further ado, I'm going to go ahead and turn things over to Dr. Howarth, who will share her slides and her presentation today. Thank you for joining us.
Thank you so much, Josh. I appreciate that. All right, let's see if this works.
That looks good. Yep.
Looks good? Awesome.
Yep.
Phew. All right, so I certainly appreciate the opportunity to talk with you all today and share some of the exciting things that we are learning about anti-NMDA receptor encephalitis. So as Josh mentioned, the title of this talk is Pharmacologic Treatment and Early Rehabilitation Outcomes in Pediatric Patients with Anti-NMDA Receptor Encephalitis. So the learning objectives include to provide an overview of NMDARE, including epidemiology, clinical presentation, and treatments, to discuss some early outcomes and management of pediatric patients with NMDARE in the inpatient rehabilitation setting, and then to review a case example and some future directions. So first, for an overview. So what is anti-NMDA receptor encephalitis besides a mouthful? It was first described in 2007. It's a recently described autoimmune disorder with a predictable clinical course. It's been found to be associated with the presence of antibodies that target against the NMDA receptor, resulting in a characteristic neuropsychiatric syndrome. So as the brain ages, the NMDA receptor becomes progressively hypofunctional, contributing to memory and learning impairments. Dysfunction of the NMDA receptor system has been implicated in various conditions such as schizophrenia, epilepsy, and dementias. So NMDARE was first described in 2007. It's a paraneoplastic syndrome. It was observed in young women of childbearing age who were found to have ovarian teratomas and presented with new onset psychosis or memory problems that then progressed to include multiple neurologic deficits. Patients often require prolonged hospitalization and recovery time. Nevertheless, they typically respond positively to immunotherapy treatments. While the incidence is unknown, recent epidemiological studies reported a higher incidence of patients with NMDARE compared to viral etiologies, with higher rates amongst females, in addition to higher rates of seizures, language dysfunction, psychosis, and positive EEG findings compared to other forms of encephalitis, per the California Encephalitis Project. Given the high frequency of psychiatric symptoms at presentation, patients may be improperly diagnosed and/or initially admitted to a psychiatric hospital, which certainly can impact time to diagnosis and treatment. So NMDARE has a predictable clinical course with 4 proposed phases. So during the prodromal phase, early symptoms may include headache, fever, nausea, and other non-specific flu-like symptoms. Next, individuals may display behavioral and/or personality changes, as well as acute psychiatric symptoms, including paranoia, hallucinations, catatonia, and/or delusions. Symptoms then progress to include various neurologic symptoms, including the emergence of seizures, autonomic instability, dyskinesias, hypoventilation, and/or decreased level of consciousness. Once patients are diagnosed and started on treatment, they typically start to recover, although recovery tends to be slow and prolonged over several months to years, with persistent deficits being documented. So the clinical presentation is similar in some ways between pediatric and adult patients. However, adolescents and adults typically present with more frank psychiatric symptoms, whereas children may display behavior changes, such as temper tantrums, increased aggression, agitation, as well as decreased speech production. It's also less common for children to present with autonomic symptoms, the presence of a teratoma, or cardiac dysrhythmia. So a large observational study was conducted in 2013, which included a sample of approximately 600 individuals. This graph displays some demographic characteristics by age at onset. So a majority of patients were female, as represented by the pink and red bars, the pink bars being female patients with no tumor, the red bar being female patients with tumor. Compared to males. Males are depicted by the purple and blue bars, purple being no tumor and blue being males with tumor. And approximately a third of patients were younger than 18 years of age. The presence of a tumor was more common between the ages of 12 to 14 years, with 94% of tumors being reported to be an ovarian teratoma. Asian and African American patients were more likely to have a teratoma than Caucasian and Hispanic patients. So this slide shows the initial symptoms by age, with the first pie graph showing patients who are less than or younger than 12 years of age. In the middle, patients who are 12 to 17 years. And then over here, patients who are greater than or equal to 18 years of age. So approximately 50% of children younger than 12 years presented with seizures or movement disorders, whereas 65% of adults presented with behavior changes. Adolescents tended to present with a combination of symptoms. So this slide depicts the cumulative symptoms experienced within the first month across the lifespan. So regardless of age, the most common cumulative symptoms included behavior and cognitive changes, memory deficits, speech disorder, seizures, movement disorder, and loss of consciousness or decreased responsiveness. So the diagnostic workup typically includes neuroimaging, EEG, pelvic ultrasound to look for the presence of a teratoma, and an LP or lumbar puncture, with diagnosis being definitively confirmed through testing of the cerebrospinal fluid, the CSF, and or the serum for the presence of NMDA receptor antibodies. So interestingly, approximately half of cases may have abnormal neuroimaging findings, although results are not consistently reported across studies. The areas that are impacted are quite variable and non-specific. Various reports have implicated the medial temporal region, cerebral cortex, cerebellum, basal ganglia, brainstem, areas of multifocal enhancement, subcortical white matter. So really neuroimaging is quite variable in this population. While limited, some recent studies have demonstrated resolution of some abnormalities following treatment, particularly if a tumor was present and surgically removed. There was a recent case study out of China that demonstrated resolution of multifocal subcortical white matter lesions following treatment with PLEX, or plasma exchange. So treatments may include first-line treatments, and first-line treatments are considered steroids, intravenous immunoglobulin, or IVIG, and or plasma exchange, which is PLEX. Second-line treatments include rituximab, cyclophosphamide, and more recently Cytoxan, as well as various medications for symptom management. So common symptoms that are being managed with medications may include agitation, psychiatric symptoms, seizures, disordered sleep, movement disorders, and cognitive dysfunction. So I'm happy to stop there if there are any questions before moving into early outcomes and management.
I'm not seeing any just yet, so maybe you can continue, but as a reminder to everyone, feel free to submit your questions to the Q&A box and we can address them as we go or at the end. Thank you.
Yeah, all right, let's do it. So now I wanted to switch gears a little bit and talk about some early outcomes and management for pediatric patients with NMDARE. So an original case series reported approximately 75% of patients having a full recovery or mild deficits, which was determined by return to work or returning to most activities of daily living. Authors indicated better outcomes and fewer relapses for those patients who were found to have a tumor and received early treatment, including tumor resection and immunotherapy. Despite substantial recovery, relatively few studies have reported on functional or cognitive outcomes of patients with NMDARE, specifically pediatric patients. So in some early studies of cognitive outcome, they predominantly consisted of case series or reports. So in a case series of 6 pediatric patients, Hautrau and colleagues reported good progress during inpatient rehabilitation, yet persistent functional deficits at discharge based on WFIM scores. Fink and colleagues examined cognitive deficits in a sample of 9 adults who were on average 28 years of age and approximately 43 months out from onset. Results suggested persistent cognitive deficits in a majority of patients, specifically in the areas of executive functioning and memory, and they also indicated that early initiation of treatment may be associated with improved outcomes. In a case study of a 29-year-old female, Vaughter and colleagues reported that the patient continued to display persistent memory deficits at long-term follow-up. So in recent literature or the existing literature, the neurocognitive domains that are reported to be impacted often include attention and executive functioning skills, memory, specifically verbal memory, aspects of language functioning, emotional behavioral functioning, and also aspects of sleep, with many individuals demonstrating memory deficits throughout the early course of the disorder. So as described, the symptoms associated with NMDARE are multifaceted and can contribute to declines in motor functioning, self-care, and cognitive linguistic skills. Intensive rehabilitation services are important in the early phase of recovery to assist with symptom management, medication management, and to monitor improvements as well as indicators of deterioration. So the patterns and predictors of recovery from encephalitis in general and NMDARE more specifically are poorly understood as there is limited research in pediatrics. In a previous case series examining the functional status of children with various forms of encephalitis in an inpatient rehab setting, Taylor and colleagues concluded that patients demonstrated significant functional gains throughout admission, which was demonstrated by change in WFIM DFQ scores or developmental functional quotient scores, which I'll talk about in just a moment. But the degree of recovery was quite variable across patients. So real quick, just wanted to give a little bit of information about our inpatient rehab unit here at Children's. So our comprehensive inpatient rehab unit, or CIRU, it's a CARF accredited 28-bed unit. We admit patients between the ages of 0 to 21 years of age, and patients are admitted when they are medically stable and able to participate in at least 3 hours of therapy per day, including OT, PT, and speech therapies. We also are fortunate to have a large multidisciplinary team, and our team consists of the medical providers, rehab therapists, neuropsychology, pediatric psychology, social work, teachers, case managers, chaplains, recreational therapists, music therapists, and child life specialists. We actually also have a therapy dog named Allie, who's also on the unit to work with our patients. One of the great things about our unit also is that we have access to consult various medical specialists across the system. So children with NMDARE who require inpatient rehabilitation commonly experience cognitive and linguistic deficits. And so neuropsychology really assists with serially monitoring the cognitive status of these patients during inpatient rehab. So the rehab team assesses functional and cognitive status upon admission and discharge using the Functional Independence Measure for Children, or WFIM. And then a subset of patients are also administered the Cognitive and Linguistic Scale, or the CALS. So the WFIM is an 18-item measure that assesses mobility, self-care, and cognition. It's commonly used in the rehabilitation setting. Given the wide range and effective age on ratings, WFIM DFQ scores were used. So the DFQ, or developmental functional quotient, represents the percent of age-appropriate functioning, which then allows for comparison across age groups. Certainly objective assessments for monitoring cognitive status are limited in NMDARE and needed to assess ongoing cognitive recovery and also treatment response. So the CALS, the Cognitive and Linguistic Scale, it's a 20-item measure. It was developed by a neuropsychologist and speech language pathologist at Kennedy Krieger. It's used with pediatric patients during inpatient rehab, and it can be used to serially track cognitive linguistic recovery following acquired brain injury. Scores on the CALS range from 20 to 100, and it can be administered in 30 minutes or less. So the cognitive domains that are assessed with the CALS include arousal and responsiveness, aspects of attention and behavioral regulation, processing speed, orientation and new memory, language and visual spatial processing, problem solving, and deficit awareness. Previous research has demonstrated significant improvements in CALS scores at admission and discharge with a pediatric TBI population. Overall, though, little is known about the early outcomes and/or symptom and medication management of pediatric patients in the inpatient rehab setting. To our knowledge, no studies have examined the use of the CALS to monitor early cognitive linguistic recovery of patients diagnosed with NMDARE. So I wanted to discuss some recent research that's been done or is being done at our institution for patients with NMDARE. So these studies that I'm going to talk about represent a portion of the patients that we have seen here. Our database now includes almost 50 patients, 50. That doesn't sound like a lot, but based on the existing literature, that sample is quite large compared to other studies that have been done. So our patients were identified via retrospective chart review dating back to 2010 and include pediatric patients with a confirmed diagnosis of NMDARE who required intensive inpatient neurorehabilitation following acute care hospitalization. A majority of patients are female and African American or Hispanic, compared to a smaller percentage of Caucasian patients. On average, children were 10.5 years of age at the time of symptom onset. Average time to initiate treatment or initiate first-line treatment was approximately 30 days, and length of stay on the inpatient rehab unit ranged from 14 to 108 days, with a mean of 40 days admission. So the most common initial symptoms in our sample included flu-like symptoms, behavioral changes, or altered mental status. In addition to these symptoms, the most common cumulative symptoms included seizures, movement abnormalities, insomnia, mutism, and agitation. MRI and EEG findings were abnormal at some point during the disease course for approximately 55 to 70% of patients, respectively. As expected, a majority of our patients had abnormal CSF or serum findings, and only 15% of our patients were found to have a teratoma, which is consistent with the pediatric literature. So with regard to treatments, a majority of patients received steroids and or IVIG. Approximately half of patients received Plex, and 70% of patients received rituximab. The use of cyclophosphamide was less common amongst our patients. A majority of patients received at least 3 first or second line treatments, and also a variety of medications were used for symptom management. So we examined WFIM DFQ scores at admission and discharge. And in our sample, we saw significant improvements between admission and discharge WFIM total and domain scores. We further examined individual changes in WFIM scores across admission, and again saw a lot of variability. Across domains, we observed a cluster of patients who demonstrated minimal to no change. We kind of deemed them low responders or demonstrating low responsiveness. So then we examined discharge DFQ scores to determine the level of dependence at discharge using a cutoff score of less than 30 for dependence, 30 to 84 for partial dependence, and greater than 85 for independence or age-appropriate functioning. So despite functional improvements seen with a majority of our patients, as you can see here, we're still seeing persistent functional impairments at discharge from inpatient rehab, with a majority of patients remaining dependent or partially dependent across functional domains. So for that subset of patients for whom we had CALS data, findings demonstrated notable change in admission and discharge scores at the group level. When we look at individual scores and changes across admission, again, we're seeing a lot of variability. So with regard to the CALS, there appeared to be 3 clusters of patients who emerged. So those who came in low at admission and stayed low at discharge, so those who maintained kind of this decreased level of responsiveness. Those who came in low at admission and left high, making more notable improvements on the CALS. Those who came in a bit higher at admission and left high with some improvements on the CALS. And then we also had one patient who came in high at admission and then displayed indicators of deterioration that were actually more in real time that were not able to be captured by the WFIM. So essentially at admission, about half of our patients presented with decreased levels of consciousness as defined by a CALS score of less than or equal to 35. And by discharge, about 17% of patients continued to display a lower level of consciousness or responsiveness. So we found that the CALS was highly correlated with the WFIM DFQ total and subdomain scores at admission and discharge. So similar to the TBI literature, we expected that younger children may be more vulnerable to brain disruption. So using a cutoff of 8 years of age, we found that patients who were younger than 8 years were more likely to have abnormal EEG and worse WFIM discharge scores. Those who were greater than or equal to 8 years of age were more likely to present with psychosis and experience auto instability. So they potentially needed a trach or a vent or a vent. With regard to disease complications, patients with an abnormal EEG were more likely to have flat or limited change profile on WFIM regardless of age. And patients who had a teratoma, again, that's a very small percentage, they were found to have lower initial WFIM scores, but no difference in WFIM scores at discharge. We also examined the influence of time to treatment. So patients treated within 1 month of symptom onset had larger change scores and better discharge WFIM scores, although findings were not significant. They were trending towards significance. So while a significant correlation was not found in our group early in recovery, it certainly may become more pronounced over time. So in terms of some early outcomes, we found that our patients were making significant functional gains during inpatient rehab despite persistent deficits at discharge. Younger age at onset, the presence of abnormal EEG or seizures, and higher number of treatments received was associated with worse functional outcomes at discharge, and time to treatment was not significantly associated with early outcomes in our sample. So as I mentioned, there's a variety of medications that are also used with these patients for symptom management. So in a separate study, we examined the number and types of medications prescribed and noted that the overall number of medications used decreased by discharge from inpatient rehab. So with regard to symptom and medication management, symptoms were grouped into 6 categories. So that included agitation, psychiatric symptoms, seizures, disordered sleep, movement disorder, and cognition, with some of the different medications that were used in these different groups. So this table illustrates the percentage of patients in our sample who were prescribed medication to treat the symptoms, the total number of different medications used, as well as the range and mean number of medications used per patient. All right. So during admission, a majority of patients received medications to treat agitation, psychiatric symptoms, seizures, and insomnia, compared to a smaller percentage of patients receiving medications to treat disordered movements and cognitive dysfunction. From admission to discharge, we found that 3 categories of medication decreased, so less medications for agitation, sleep, and anticonvulsants, whereas 3 categories of medication increased during inpatient rehab. So those for cognition and arousal, psychiatric management, and movement, disordered movements. So essentially, I think the takeaway from this is that patients with NMDARE are often medically complex and heterogeneous, and the number of symptoms to treat and medications being used to treat them presents a challenge for medical providers, namely polypharmacy. The amount of medications that these patients are on is really pretty remarkable. Clinical decision-making rules are not well established or understood, and there really is a need for kind of an algorithm or an established way of offering guidance and or allowing providers to systematically approach the medical management of these patients while taking into account both the neurology and psychiatry perspectives. One of our colleagues, Dr. Josh Voba, he recently published a narrative review on considerations for pharmacologic management of these patients, which is certainly worth a read if that's of interest and in your free time. It's also important to consider the impact of symptom and medication management on early outcomes during inpatient rehab. So as previously described, we examined individual changes in WFIM scores across admission and saw a lot of variability. We observed a cluster of patients who demonstrated minimal change. And so therefore, patients were divided into 2 groups based on change in total WFIM score throughout admission. And we deemed sort of this group here in the red as sort of our low responders or those with unfavorable early outcome. With regard to early outcomes, one way ANOVA revealed that younger age at treatment, so lower responders, tended to be younger than those who did respond. Hierarchical logistic regressions demonstrated that, with regard to medication management, treatment for seizures, treatment for movement disorders, treatment with 2 or more antipsychotic medications, basically those were predictive of low functional gains after controlling for age. However, there was a trend, after controlling for age, treatment for seizures and movement disorders were predictive of low functional gains, whereas there was a trend for patients treated with 2 or more antipsychotic medications to show higher functional gains during inpatient rehab. We didn't find any differences with treatment for sleep, agitation, or use of first and second line treatments. And overall, current findings suggested that younger age, treatment for seizures, and treatment for movement disorders may be associated with increased risk for worse functional outcomes following inpatient rehab. So in this study, all patients received first line and approximately 70% received second line immunotherapies. Patients were prescribed on an average of 8 medications for symptom management, most often for the treatment of agitation, psychiatric symptoms, and seizures. A majority of patients demonstrated improvements in total WFIM DFQ scores, while there was a subset of patients that demonstrated little to no change, deemed unfavorable early outcome, independent of age. So certainly these findings highlight the symptomatic heterogeneity and polypharmacy that's involved in NMDARE, as well as the need for further investigation of clinical presentations or treatments and how differences are associated with outcome. All right, so now I wanted to briefly share about a case example. Josh, I just wanted to check in to see if there were any questions or if I should continue.
Yeah, there actually was one that might be related to talk about now. The question was, have you looked at outcomes post-discharge? So for example, like a third time point several months later, and if so, do the 3 main trajectories continue to follow the same trend?
Yeah, that's a great question. That's something that is in progress. Yeah, there has been some recent work that we've done. There's something called the NEOS. What it stands for is escaping my mind at this moment. But the NEOS is basically a scale that has been developed with NMDARE to look at outcomes like 1 year out. And so we have started to look at, over time, how can we sort of see the way that these different trajectories play out? Are they maintained? Do they change? Because I think that's something that's really important for us to understand. I know part of what I have seen clinically is, thinking off the top of my head, 3 different patients who had a decreased level of responsiveness while they were on the inpatient rehab unit, seeing them in clinic kind of over the first year after they discharged, and they definitely emerged and were more interactive to varying degrees. But I think that that's a really important thing to look at, and that's something that our group is working to certainly examine with our sample. And I know that it's being looked at with some additional groups as well.
Great, thank you so much. Yeah.
There's a lot to learn. I was talking with a parent one time recently. Her 19-year-old son was on our unit with NMDARE, and no tumor was found. So really there's so much uncertainty, meaning what caused this? And so she was going through all of these things. Is it his ADHD? Did that cause it? We have mental health issues in the family. Did that cause it? She's like, I just don't understand how we don't know. And so that's part of what I explained to her also, is that, even though it feels like we've known about NMDARE for a long time, from a medical and research perspective, it's really in its infancy in terms of our understanding. And one of the big things with pediatric patients is a majority of them don't have tumors. And so what is it that triggers this autoimmune response? It's just something that is really not very well understood. All right, so let me talk with you briefly about a case example, just to sort of illustrate a little bit about how this can look during the early phase of recovery on the inpatient rehab unit. So we'll call her Sky. So Sky was a 16-year-old African-American female who presented with a 2-week history of headache and fever. So in kind of mid-October, she was brought to the ED. She presented with, sort of these new onset headaches, fever. She was reporting that she was not feeling like herself, or she was feeling outside of her body. Not uncommonly, all of her diagnostic tests were negative, and she was discharged home. So then at the end of October, she was experiencing worsening symptoms. So worsening symptoms of agitation, confusion, the development of hallucinations, and she was subsequently admitted to an inpatient psychiatric facility. Over the course of the next couple of days, though, her symptoms continued to progress to then include more neurologic symptoms such as twitching, left-sided facial droop, drooling. She was discharged home. I don't know why, but she was discharged home with a plan to follow up with neurology in a couple of days. She was reporting, dizziness, confusion, episodes of tremor, facial droop, tongue protrusion, and torticollis. So she was having the development of, multiple new symptoms, including some neurologic symptoms. A couple days later, before her neurology follow-up appointment, she was back at the ED at an outside hospital. Again, symptoms were continuing to progress and worsen. She now presented with decreased responsiveness, as well as visual hallucinations. Her neuroimaging, head CT and MRI, were normal. Her EEG was consistent with seizures, and they did do a pelvic ultrasound, and it did not reveal any evidence of an ovarian teratoma or tumor. So she was ultimately found to test positive for antibodies, NMDA antibodies in the CSF and serum. She was started on immunotherapy, which included steroids, Plex, rituximab, and Cytoxan. So she came from out of state. So she was actually in the Memphis area, and then was transferred to our day rehabilitation program. So our DRP is an intensive outpatient rehab program that's located here at our hospital on this campus. Shortly after admitting, she displayed increased insomnia, agitation, aggression, and more frank psychiatric symptoms. During a speech therapy session, she was described as kind of being somewhere else. She started undressing, so just very bizarre behavior. So then she was subsequently admitted to our inpatient rehab unit, where she stayed for 44 days. That's a pretty long admission for our patients. She received intensive speech, OT, and PT services, and she was followed by pediatric psychology, neurology, and psychiatry, in addition to our rehab physicians. So just a little bit of background for Sky. So there were no complications with pregnancy, birth, development prior to any of this. Her medical history was quite unremarkable. She was described as a good student, AB student. She enjoys school, no history of formal support services, no history of learning concerns. In terms of family and psychosocial history, she lived with her mother, younger sister, and grandmother. Family history was reported to be significant for learning differences and substance abuse. Overall, she was described as a pleasant, well-behaved, strong-willed teenager who's a good self-advocate, who has a very bubbly personality and is actively involved in cheerleading. So in terms of my initial assessment with her, so when I saw her, it was 88 days from onset. And at that time, her initial CALS score was a 52. So again, the CALS ranges from 20 to 100. The scores do not equate with any kind of standard score or percentile. It's simply a raw score. So for her, she had an initial score of 52. In terms of behaviorally how she presented, she was awake, alert, and responsive to the environment, but she definitely vacillated between periods of lucidity and confusion. She was very impulsive, very perseverative. She had intact functional communication, and she was able to follow simple one-step commands and provide short verbal responses. The quality of her speech was very pressured and nonsensical. When asked to generate a story about a visual picture, she kind of started talking about things that were pertaining to the picture, and then it became very tangential. Her speech then started to follow a cheer cadence, and she also started to do kind of cheer movements as though she was doing a cheer. It was as though she was somewhere else. She was not oriented. Her new memory was quite impaired. She presented with a tremor in her bilateral upper extremities, and she had flat affect and limited insight into her deficits. For me, with this patient, one of the most striking things about her was her clock drawing, which I think kind of can really demonstrate a little bit about how she presented more than anything else. So this was her initial clock drawing. So as you can see, she started out 1, 2, 3, 4, 5. You see a 6 in here, you see a 9 over here. So she started out okay, and then it just became very confused. She became very dysregulated. She was very perseverative. She was kind of mumbling to herself. It had a very psychiatric presentation, a very psychiatric flair. So then over the course of her admission, I did clock drawing with her each week. Again, the second week, very confused, still very psychiatric in terms of her presentation. By week 3, it's looking a little bit better in the sense that we have numbers. What you'll see is that over here, she started going backwards. So 12, 11, 12, 13, 14, 15. So again, pretty notable confusion, although certainly improved. So then the following week, still having some difficulties with her visual organization, but the overall orientation in terms of the content continues to get better. And then by her discharge, it looks more appropriate, even though, of course, there are still some difficulties with the visual organization. And this kind of coincided with what she behaviorally looked like at discharge. So at discharge, her assessment score, or her CALS score, was an 85. At this time, she was 121 days out from onset. So at discharge, she was awake, alert, responsive. There was minimal evidence of confusion, agitation, or perseveration. She had improved impulse control. Her functional communication was intact. She was now following multi-step commands, providing fluent verbal responses. She still had some instances of pressured speech, yet the content of what she was speaking about was appropriate. She was fully oriented and recalling new information over 24 hours. There were no longer any observable tremors, and she did display a broader range of affect and improved insight into her deficits. So now just to kind of briefly chat about some future directions, and then I certainly welcome questions, comments, and thoughts. So certainly given the heterogeneity of this patient population, it appears that different clinical presentation or symptoms and medical treatments may be related to differences in early recovery. There certainly is a need to establish a systematic approach or algorithm to the pharmacologic management that considers both the brain injury and psychiatry perspectives. Following inpatient rehab, there's a need for ongoing monitoring of functional status over time to better characterize the cognitive deficits and trajectory of recovery. And further, we hope to continue to see these patients over time to conduct more comprehensive neuropsychological evaluations to just better characterize cognition and recovery. Future studies should focus on identifying and examining predictors of severity, response to treatment, and functional recovery over time with larger samples. Certainly some of the things that have been talked about in the literature is looking at biomarkers, and are there ways from a biochemical perspective that we can better understand which patients may be better responders to certain treatments. Certainly age at the time of onset, looking at the presence of different disease complications, time to treatment, and various medications that are being used. I think one interesting finding from our studies, and that we've kind of just noticed over time, is kind of a need to explore racial ethnic vulnerabilities associated with NMDARE. Certainly while NMDARE has been described worldwide, racial ethnic demographics are often not included or directly examined. There have been a few previous international studies that potentially found an overrepresentation of non-Caucasian patients. Certainly being here in Atlanta, which is a very diverse metropolitan area, we do have a large number of non-Caucasian patients that are on our unit. However, what we have found is that when we look at the demographics across other admissions on our unit, it does seem to have more of an overrepresentation of non-Caucasian patients. We also have patients, a lot of them who are from outside of the Atlanta area, outside of the state of Georgia even. So not sure what that's about. Certainly these disparities have not been reported in other types of encephalitis. And so potential explanations remain unclear, but certainly worth examining in future investigations. So in conclusion, children with NMDARE often show early functional and cognitive improvements during inpatient rehabilitation, despite persistent deficits at discharge. Symptom management with NMDARE often involves polypharmacy that needs to consider both the brain injury and psychiatry perspectives. Possible predictors of early recovery may include younger age, presence of seizures, higher number of treatments received, as well as treatments for seizures and/or movement abnormalities. And this certainly highlights the importance of ongoing monitoring of patients over time to better understand the trajectory of recovery, as well as to identify appropriate interventions. So I appreciate your attention and welcome any additional questions.
Yeah, give me just 1 second here. So thank you so much for this interesting talk. It's always great to hear about autoimmune disorders in general, because I think kind of like you've hinted at, I think throughout this talk, there's quite a lot of heterogeneity, it seems, to the presentations, even within a specific receptor disorder in this case. So one question that we had come up that I think is of interest, given that a lot of our audience, we have people across the professional spectrum, even later career professionals join us sometimes. But we do, I think, No Neuropsychology highly gear our presentations towards trainees and early professionals. So in general, for a trainee or early career person or just somebody who wants to know more, are there kind of more broadly, are there resources like textbooks or print or electronic ones you'd recommend people look at regarding sort of autoimmune disorders more broadly and sort of their neuropsychological sequelae?
Yeah, that's a great question. I would say for NMDARE specifically, one book that people have probably heard about by now is Brain on Fire, which I think is it's a good read, and it's a firsthand account of a young woman who was in her early to mid 20s who was diagnosed with NMDARE and basically kind of went through the progression of the stages of how it presents. And she had absolutely no memory of her hospitalization, and so essentially wrote it after interviewing her doctors and reviewing video EEG footage and all of those things. So that's one that's kind of just to sort of understand a little bit of the nature of this particular disorder. I think, what is it called? There is a group, it's like, Josh, I'll have to look it up and get back to you, but there is a website, it's like Encephalitis. I don't want to misstate it. So let me find it and I'll email it to you. But I know that there is a really nice website with good resources, not just for trainees and professionals, but also for families. Because a lot of times families are like, what is this? How do I learn more about this? How can I maybe find other people who have children or loved ones who have been through this also? So it could potentially be a source of support as well. So I will find that and send it to you as soon as this is done. I just don't want to give the wrong name.
For sure. Yeah, we always appreciate including these resources with the accompanying talks on the website. That way that can be a resource to future people. One more question we have, and maybe we can end a couple minutes early for people who want a little break. So one more question we have, kind of, especially with a condition like this, where a lot of the research, there seems to be a lot of exciting research that your group and others are doing, which is really exciting, I think, shows a lot of promise for the future of the care of these individuals. But how do you view your role now as a neuropsychologist with a condition like this, where there are often, I guess, kind of unclear prognostic implications? What's sort of your approach to feedback or talking to these families?
Yeah, I think that that's hard, right? I think it's hard when we don't know, but I think a big part of at least what I do is I acknowledge that I don't know. I also talk about what I do know. And so, especially from our assessments, I think that as neuropsychologists, we're in a really unique position to be able to offer families a lot of good information about what their loved one is able to do and what strategies may be helpful or important for meeting their needs at different stages of recovery. So I view the role of neuropsychology to kind of help empower caregivers and loved ones to just best understand what's going on with their loved one and provide a rationale for why we want to monitor this over time. Our hope is that this will continue to improve, and what we know from the existing literature is that most people do improve, but we want to see we want to monitor and let your loved one be our guide. And yeah, I acknowledge that we're early in our learning of this disorder, but now it is on the radar of a lot more doctors, of a lot more institutions, which is really encouraging. So I think, again, sort of talking about what we're able to learn about a person's cognitive status as neuropsychologists, and talking with families about what we do know about the disorder, really to kind of normalize. I find that families usually will give me the play-by-play, and it's long, of kind of what they experienced. And so I also view neuropsychology as this unique entity to be able to allow space for families to share and then validate, yep, that's really common in this disorder. And that must have been really stressful and really hard. So I think that's where our psychology training comes in as well.
Yeah, absolutely. I think I've heard many people say we're psychologists first and neuropsychologists second. So it's good to balance those.
Lots of hats.
Yeah,
yes, lots of hats.
Maybe yeah, exactly. Maybe we'll need to have you come back. I think we should have you come back in a few years and give us an update, especially with this emerging research about the 3 time points and other things like that. It's so great to have you join us today. I really, on behalf of everyone, on the call and whoever watches this recording in the future, I wanted to thank you again for joining us today, Dr. Howarth, and sharing your expertise about this disorder with us. It's really quite an honor to have you join us. And just one quick note for everyone. So next week we'll have our final No Neuropsychology lecture in this volume. So the last one for 2021 before we start the new year. And that will be with Dr. Donders, who will be joining us at the same time as this talk, so 11 o'clock Eastern time, 8 a.m. Pacific, to talk about neuropsychological report writing. So a nice complement to many of these research and clinical talks that we've had throughout the series. Thank you again, Dr. Howarth, and thank you everyone for joining us today. Bye.
Sure. Thanks.
Bye. See ya.